So my name is Thomas Thompson. I'm the Assistant Director of Nursing and the co-lead for Rpiw 50 Team Golden Eye. So our project form was to eliminate inconsistencies in process for delivery of specialty drug compounds for eye treatments and provision of financial information for patients. This improvement is directly related to the provincial motions that cover and support our culture of safety, support clinicians in utilizing agreed upon best practices, and to achieve a balanced budget. So part of our current situation is that there was lack of communication about patient changes, switches to workload, especially in the different staffing departments of ambulatory care, pharmacy, and the OR. There was also no standard work for what was required when receiving the orders and the slates from the physician's offices. Billing procedures also did not often have the correct client and drug information on it. So our theme was that all patients receive their specialty compound without delay and are financially informed. Some of our base target progress reports are the 5S, pharmacy, an open area to shelves. We measured our carts traveled, and for this we used the bill that travels with the patient, from the patient and the printer. We also looked at our quality metrics and measured the number of times inaccurate clinical data patient information was received for the injections and billing, and also tracked the canceled patients and the number of times changes were made or due to the wrong slate, and also the percentage in OR schedule not being provided to pharmacy. We also wanted to see if we can increase our productivity gain for the pharmacy tech to be able to get accurate clinical data for each patient. So our pre-Kaizen value stream map, actually, when we looked at the whole cycle in pharmacy, we felt that there wasn't a lot that we could improve on in how they prepare all the compounds. So it became evident as we kind of went through all the problems that this became more of a quality improvement, a value stream map. So some of the data that we did look at was our PKA data was about the sterile compounding. We found that they did about 2 knees a month. The eye gels, they did about 29. And eye injections, they did Lucentis about 52 and Eylea about 27. So then we really looked at the flow of these patients and the billing process for them. So our pre-Kaizen fishbone diagram, we identified 23 factors that contributed to our project form. Our TAC time, we measured the time for the billing for Lucentis clinic of our pharmacy tech, and her TAC time was 11 minutes and 4 seconds. So this percent load just shows the amount of sterile compounding procedures for the knees, the eyes, and the Lucentis and the Eylea. So this is the Eylea and Lucentis. We just started giving this injection as a district in about 2013. And for the last couple of years, you can see that in 2013, we had 12 clinics. And just in a couple of years, we've already done 26 clinics. The Eylea injections just started this year. And you can see that they've already given in the last first 3 months of the year 33 injections, and they've served 27 patients. So this is the Lucentis, and when we started, the number of patients we served were 201. We now, in the last couple of years, are up to 628. The number of injections were 280, and we're 870 now. So this clinic has grown quite a bit. This is the amount of time that it takes for just the clinical data entry. That whole time took about 12 minutes and 37 seconds. So this just shows again our percent load of the pharmacy tech when she is billing for the Lucentis. And our standard work combination sheet that shows the same data. And our spaghetti diagram, and this shows the amount of time that she has to go get her bill, walk back to the printer, and it takes about 123 feet per return cycle.
Hi, I'm Naomi. I work in pharmacy at the hospital here, and I'm a participant of Rpiw 50. So one of the problems that we recognize is that I manually write on the prescriptions from SPDP, and now I have a stamp. So this is what the before looks like and what I'd have to write. And then after, since I have a stamp, I can just stamp it so it'll make it more efficient. Another problem we found was changing the prescription slate from the times of each patient, and now for their appointment time, and now for the slate will be in alphabetical order for patient name, and that'll make my billing process a lot more efficient. So from that, we made a standard work for the prescription slate that's used in ambulatory care, so that all the staff do the same process, so that when I get the slate at the end of it, I know that each nurse did it and it's all the same all the way through. So we did multiple skills training, and we have everyone except for 2 people that are trained. We did work standard for ILEA and Lucentis process between Dr. Khan's office and pharmacy. One of the other problems that we discovered is pharmacy sends over SPDP receipts to finance, and we do that manually at month end. So something that we proposed as a solution was to send over electronically so patient could receive their bill sooner, and so the patient could pay outstanding amounts. Standard work of the billing for ILEA for the inventory tech, which I never had time to do before. So now I have standard work for ILEA all the way through the whole billing process, right to the end. And we also did the same for Lucentis. Another problem that we found was storing patient receipts and filing. It was a very long process. So the solution is possibly saving to the end drive to share with finance electronically instead of manually inter-office mailing it to them. This is me and my frustration and all the filing and all paperwork. And then another thing is checking the electronic statements, which if there's a problem, it'll tell me right away I won't be able to proceed. So I shouldn't have to check because really it's okay because it's given me a final receipt.
Good afternoon, my name is Johan Huson from the IT department, and I'm a participant in this Rpiw. So one of the problems that we encountered is that pharmacy does not have knowledge or have little knowledge of the OR slates. So it ends up they would scramble or call the OR scheduling or the OR itself to know how much mixtures that they need to do for the surgery happening the next week or the following day. So they end up, most of the time they end up doing more mixtures than what is needed for the day. So what we trialed, at first originally we thought why not ask OR scheduling to send a slate to pharmacy at the before the week before the surgery will happen. But we thought of during this week, why not have them access to OR scheduling, the OR manager, so they can have direct access to the schedules. So what we did is trained all the pharmacy techs, and I think we're only left to train for next week.
Good afternoon, I'm Claudia Driscoll, and I have been a participant representing patients and families. And what we were looking at, our whole focus has always been the client. And we had to look at what happens at Dr. Khan's office and what happens up here at the hospital. We also kept very much forward that the clients that are coming for the injections have visual impairments, mobility issues, come with support person, chronic illnesses, and some cognitively impaired. So we wanted to look first at Dr. Khan's office as to the entry point for a new referral. And we worked closely with Brenda, the office manager or doctor assistant, on Thursday. Now, what we learned from Brenda was the information that she gives to the client is an appointment date, location, and then Dr. Khan meets with the person as far as education material, and he is so thorough, so wonderful as far as the information he gives to the client in his office regarding the eye disease treatment, and all the material that's given is reader friendly. So after we looked at what Brenda does, with her help, the appointment sheet was revised to include the visit to the hospital, including admitting, what to do at admitting, ambulatory care, and parking. Yes, the information regarding costs was not present at the first visit with Dr. Khan and his staff. No information regarding cost, payment, cost reimbursement, and great confusion regarding the bill payment. After now, there has been an implementation of this information, which is attached to Brenda's sheet regarding the appointment. And that handout will hopefully guide and give options available to help with their eye injection costs. We had the opportunity then, we thought it was important to interview people, both at Dr. Khan's office and at the hospital. And we did that yesterday, June 2nd. The results. Concerns were voiced: wait time, payment confusion, costs, travel time. We interviewed 13, some coming as far as Hudson Bay, Creighton, Debden, Melfort, Shellbrook, and of course Prince Albert. And one gentleman we interviewed had taken the day off without pay. And he does that every 4 to 6 weeks. All the people we interviewed were so supportive and want all services under Dr. Khan's office. And yes, one lady said if she could be so fair is to say one-stop shopping. The other concerns that were expressed by the client was the exposure at the hospital to possible hospital infections. Thank you.
Hello, I'm Carol Bergrick. I am the co-lead for the Rpiw 50 GoldenEye. Prior to the Rpiw week, we did do a 5S event in pharmacy. They have done a lot of 5S and Kanban, so we were just confined to this cupboard. As you can see, we have items on the top, one of which was a first aid kit or emergency kit, as well as a variety of written information, and that's posted that isn't always clear. With the emergency kit, we discovered inside of it there were only flashlights, and in the coffee area was the rest of the first aid kit with birthday candles and toothpicks. So our pre-5S score was 1, and our post-5S score was 2.5. And we did have 179 items in our area that we were 5S'ing, and we ended up with 32 items at the end of it. As you can see, we did laminate a couple of the items that they're using all the time. That was just one was just a written sticky note, and we combined their first aid emergency kit to a real one and made it more accessible, especially if it happened to be a power failure. This is the time observation sheet post that we did on the clinical data entry that the pharmacy tech does do, and we reduced that time to 8 minutes and 5 seconds. As well, as a reduction to the 8 minutes and 5 seconds, this percent load chart shows that we have been able to reduce the pharmacy tech's workload in that cycle below their attack time. And again, the standard work combination sheet shows the same reduction of time. The post-Kaizen fishbone diagram, we had addressed 18 factors with a 78% improvement. The items that are left on this fishbone really revolve around the movement of that clinic to a one-stop shop. This would be, and will be, it's one of our items to follow up on, having that electronic billing process, which Naomi and I checked out this morning. The clinic was just yesterday, so we were only able to check that out this morning. We would have 0 walks, but Naomi likes walking, so we'll have to fix that too. Our newspaper, we now have just a few items left to do. There's a bit of standard work rewriting around the knee cocktail that requires updating. There's login updates for pharmacists and techs that we didn't quite get to. We also have the travel, if we can move the clinic, and that's the other big piece, is to move that clinic so that the eye injections are received in the office. And also the printing and checking of receipts electronically is another item that's left to do. So our post-target progress report sheet, we have lots of 100% on here. We're so very proud of our target report sheet. And we did look at the next one. Reducing the defects in the clinical data of patients for injections, the canceled patients. Because of the new process we put in place in ambulatory care with the slate prescription, we reduced that to 0 for canceled patients, 0 changes in the wrong slate, and we've also reduced the amount of time the pharmacy is not able to know what's going on in the OR to 0 with access to OR manager. And we've increased the productivity of the pharmacy tech by 50%. The post-Kaizen value map, as you can see, we've addressed a number of the issues that were happening up front around the billing and the information that the patients were being provided. And then as well, at the end of the process, when the appropriate bills were being sent and the proper documentation of the clinical data for those patients, so that everybody was getting the right information. But the biggest thing to remember here is that the lead time from the time that patient sees the doctor and the time that they actually get the treatment is 4 hours and 43 minutes and 40 seconds, and we have bets that we can reduce that if we move this clinic all into one spot to 60 minutes. And this is just a reflection of the patient walking in Dr. Khan's office, and the office was very welcoming to us. Driving across town to the hospital, and then all of the running around they do in the hospital. So they have 277.5 feet, plus parking lot, plus the 2-kilometer drive, plus the fact that they can't see well and usually have to have someone with them. So as a result of that, and the fact that we really want to see this carried forward, Dr. Khan is willing to do a test run with us, and we have an planning meeting booked with him for the end of the month. We also have created an implementation plan to do this. And we also have created a project plan work form for everybody to follow up on. And yesterday we did get some initial timings for our patients through the eye clinic, and that led to the 4 hours 43 minutes and 40 seconds, I think it was, that we had for time for those patients to spend in that clinic. We also did a patient satisfaction survey, so when we do a test run, we can give this to the patients to say, how do you find it, how do you feel about the change, and is it a positive thing with room for comments, and you'll note that it's very big writing so that they can see it. So our workshop summary, we now have patients knowing what to expect for bills. Pharmacy can view the ORA schedule to predict compounds anytime. We reduced the percent load for the pharmacy tech to tack time by expediting the billing process. And we do have the potential massive reduction in wait time for patients by moving the injection location. So our thank yous, we do want to thank our process owners, Monique Zwack and Lori Friesen, our pharmacy staff who are also very welcoming to us, Ilona Matthias and the ambulatory care staff, Dr. Khan's office, particularly Brenda Moline, the staff, and of course the patients that were there. Our IT department who did some work for us, our KPO support, Sam and Wanda, our finance department that we contacted, and Brett Enns, our sponsor. We also contacted the eye clinic at Saskatoon City Hospital, and they were very helpful to us, both the staff and the pharmacy staff there. And we also talked to Sask Health and the prescription drug plan around the movement of the injections to the clinic and how we might go about doing that, so our thanks to them. And in particular, thanks to Claudia, our patient, who was very key on keeping us real, but also connecting the dots when we were trying to do processes that didn't make sense from a patient perspective. So thank you.